In this chapter, we will be studying the muscular system. Muscles constitute nearly half of the body's weight, and they occupy a place of central interest in many fields of healthcare and fitness, including physical and occupational therapy, athletes, dancers, trainers, acrobats, nurses, and more. The muscular system is closely related to other systems we've previously covered as well. Nurses employ their knowledge of the muscular system to give intramuscular injections correctly and to safely and effectively move patients who are physically incapacitated. Gerontological nurses are keenly aware of how deeply a person's muscular condition affects the quality of life in old age. After we have done some general studies of the muscular system in this chapter, we'll examine the mechanisms of muscle contraction at the cellular level and the molecular levels. And we'll shed some light on the relationship of the muscles to the nerves that control them. We'll be concentrating mostly on the first section of this chapter, and here are our expected learning outcomes for the first section of the chapter. And you can take a minute to pause the video and read through those. There's about 600 human skeletal muscles. They constitute about half of our body weight, and they come in three kinds of muscle tissue: skeletal, cardiac, and smooth. They're specialized for one purpose: converting the chemical energy in ATP, or adenosine triphosphate, into the mechanical energy of motion. Myology is the study of the muscular system. Muscle cells exert a useful force on other tissues and organs, either to produce a desirable movement or to prevent undesirable ones. Although we examine all three muscle types in this chapter, most of our attention will be on the muscular system, composed of skeletal muscles only. The word muscle actually means little mouse, apparently referring to the appearance of muscles rippling under the skin. Muscles enable us to move from place to place and to move individual body parts and body contents in breathing, circulation, feeding, digestion, defecation, urination, and even in childbirth. They also play a role in communication, like speech and writing and nonverbal communications, such as the expressions that you can show on your face and that others can read. Muscles maintain posture by preventing unwanted movements as well. Some are called anti-gravity muscles because, at least in part of the time, they resist the pull of gravity and prevent us from falling or slumping over. Many muscles also stabilize the joints by maintaining tension on our tendons and our bones. Muscles control body openings and passageways, such as the round muscles called sphincters. These are internal muscle rings that control the movement of food, such as food passing from the esophagus into the stomach, and bile, blood, and other materials within the body as well. In the eyelid and pupil, they regulate the admission of light to the eye. Muscles that encircle the urethra and the anus control the elimination of waste. Some of these muscles are called sphincters, but not all. The skeletal muscles produce as much as 85% of your body heat, which is vital to the functioning of proteins called enzymes, and therefore your metabolism. And muscles regulate our blood glucose, or they maintain our glycemic control. This means they help keep our blood glucose concentration within its normal range. The skeletal muscles absorb, store, and use a large share of your glucose and play a highly significant role in stabilizing its blood concentration. If we were to take a look at a muscle like this, we would see that a skeletal muscle is a lot more than just muscle tissue. It also contains connective tissue, nerves, and blood vessels. Here we see those components labeled, and we'll take a look at them from smallest to largest and from deep to superficial. The endomysium is a thin sleeve of loose connective tissue that surrounds each muscle fiber. Remember, another name for a muscle fiber is a muscle cell. So endomysium is loose connective tissue that surrounds each muscle cell or muscle fiber. This allows room for capillaries and nerve fibers to reach each muscle fiber. It provides extracellular chemical environment for the muscle fiber and its associated nerve ending. Excitation of a muscle fiber is based on the exchange of calcium, sodium, and potassium ions between the endomysial tissue fluid and the nerve and muscle fibers. The perimysium is a thicker connective tissue sheath that wraps muscle fibers together into bundles that are called fascicles. Fascicles are visible to the naked eye as parallel strands. The grain in a cut of meat, like a tender roast beef, is easily pulled apart along its fascicles. The perimysium carries the larger nerves and blood vessels as well as stretch receptors called muscle spindles. The epimysium is a fibrous sheath that surrounds the entire muscle. On its outer surface, the epimysium grades into fascia, and its inner surface issues projections between the fascicles to form the perimysium. The fascia is a sheet of connective tissue that separates neighboring muscles or muscle groups from each other and from subcutaneous tissue. Muscles are grouped into compartments and separated from each other by this fascia. So if I go back to this picture, we can find those things we've just talked about. Here we see the bone, the tendon that connects to the muscle tissue. Here's the fascia, the sheet of connective tissue that separates the neighboring muscles or muscle groups from each other. Here's the skeletal muscle tissue itself. We can see the individual fascicles inside, and then we blow that up further so we can get a better look at it. We can see nerves and blood vessels. We can see the epimysium, which is the fibrous sheath that surrounds the entire muscle on its outer surface, and then it grades into fascia. Then we can see the perimysium. This is the connective tissue that wraps the muscle fibers together into the bundles called fascicles. We see the endomysium as well, located right here. That's what surrounds the muscle fibers themselves, or the muscle cells. The muscle fibers or the muscle cells are listed here. And then this is kind of neat where they pull out a whole fascicle. And then you can see the individual muscle fibers inside there and pull it out even further so that we get the muscle fiber itself. This whole thing would constitute what's called the belly of the muscle. I would also like to note to watch your Latin and Greek prefixes and suffixes here. They might help you remember what some of these words mean, such as endo means inside. When you see the MYS, means, it means muscle. Peri means around, like perimeter. That might help you remember that one. Epi means upon or above. Fascia means band. So hopefully those will help you remember what some of those words mean. And then we can see them again at the microscopic level. Muscles come in many different shapes and sizes. The strength of a muscle and the direction of its pull are determined partly by the orientation of its fascicles. Muscles can be classified according to fascicle orientation as follows. Fusiform muscles. Those are thick in the middle and tapered at the ends. And a great example of this type of muscle is the biceps brachii of the arm and even the gastrocnemius of the calf. These are relatively strong muscles. Parallel muscles have uniform width and parallel fascicles, and they can span longer distances than other shapes of muscles can. The rectus abdominis of the abdomen is a great example of a parallel muscle bundle. The sartorius of the thigh and the zygomaticus major of the face are other examples. Because these have fewer muscle fibers than the fusiform muscle of the same mass, these produce less force than the fusiform. There's the rectus abdominis. Triangular or convergent muscles are fan-shaped. They're broad at one end and narrow at the other. The pectoralis major is a great example of a triangular muscle. This is in the chest. And the temporalis on the side of the head is another good example. Despite their small localized insertions on a bone, these muscles are relatively strong because they contain a large number of fibers in the wider part of the muscle. Here's the pectoralis major. Pennate muscles are feather-shaped. Their fascicles insert obliquely on a tendon that runs the length of the muscle, like the shaft of a feather. There's 3 types of pennate muscles, starting with this one right here, the unipennate muscle. This is in which all the fascicles approach the tendon from one side. For instance, the palmar interosseous muscles of the hand and the semimembranosus of the thigh. In the bipennate, the fascicles insert obliquely on a tendon from both sides. This one really looks like a feather. For example, the rectus femoris of the thigh is a great example of this one, shown right here. And then there's the multipennate. This is shaped like a bunch of feathers with their quills converging on a single point. For example, the deltoid muscle of the shoulder is a great example. These pennate muscles generate more force than the preceding types because they fit more muscle fibers into a given length of muscle. Circular muscles, sometimes also called sphincters, form rings around certain body openings. When they contract, they constrict the opening and tend to prevent the passage of material through it. Examples include the orbicularis oculi of the eyelids, shown in this picture here, and the external urethral and anal sphincters. Smooth muscle can also form sphincters. For example, the pyloric valve at the passage from the stomach to the small intestine, and the sphincters of the urinary tract and the anal canal. And summing it all up, here you can see the locations of the fusiform, parallel, triangular, the pinnate, and circular types of muscles. A muscle compartment is a group of functionally related muscles enclosed and separated from others by connective tissue fascia. A compartment also contains the nerves and blood vessels that supply that muscle group. Such compartmentalization occurs in the thoracic and abdominal walls, the pelvic floor, and the limbs. Some of the fascia that separate one compartment from the other are particularly thick, and these are called intermuscular septa. The tight binding of muscles by these fasciae contributes to a clinical problem described as compartment syndrome. Muscle compartments are very snugly contained in their fasciae. If a blood vessel in a compartment is damaged by overuse or contusion, which is a bruising injury, then the blood and tissue fluid can accumulate in that compartment. The inelastic fascia prevents the compartment from expanding to relieve the pressure, and then the mounting pressure on the muscles, the nerves, and the blood vessels triggers a sequence of degenerative events called compartment syndrome. Blood flow to the compartment is obstructed by pressure on its arteries. If ischemia, or poor blood flow, persists for more than 2 to 4 hours, the nerves there can begin to die, and after 6 hours, so does the muscle tissue. Nerves can regenerate after the pressure is relieved, but muscle necrosis is irreversible. The breakdown of muscle releases myoglobin into the blood. Myoglobinuria, or the presence of myoglobin in the urine, gives the urine a dark color, and it's one of the key signs of compartment syndrome. Compartment syndrome is treated by immobilizing and resting the limb and, if necessary, making an incision to relieve the pressure. That's called a fasciotomy. Next, let's look at muscle attachments. Skeletal muscles are attached to bones through extensions of their connective tissue components. There's 2 forms of attachment, indirect and direct. Let's look at indirect attachment first. In an indirect attachment, the muscle ends conspicuously short of its bony destination, and the gap is bridged by a fibrous band or sheet called a tendon. You can easily palpate tendons and feel their texture just above your heel. That's your calcaneal or Achilles tendon. Collagen fibers of the muscle continue into the tendon and from there into the periosteum and the matrix of the bone. This creates a very strong structural continuity from the muscle to the bone. In some cases, the tendon is a broad sheet called an aponeurosis. This term originally referred to the tendon located beneath the scalp, but now it also refers to similar tendons associated with certain abdominal, lumbar, hand, and foot muscles. For example, the palmaris longus tendon passes through the wrist and then expands into a fan-like palmar aponeurosis sheet beneath the skin of the palm. In some places, groups of tendons from separate muscles pass under a broad connective tissue called a retinaculum. One of these covers each surface of the wrist like a bracelet, for example. The tendons of several forearm muscles pass under them on their way to your hand. Next, let's look at direct or fleshy attachments to the bone. In a direct attachment, there is so little separation between muscle and bone that to the naked eye, the red muscle tissue seems to emerge directly from the bone. For example, along the margins of the brachialis and the lateral head of the triceps brachii. At a microscopic level, however, the muscle fiber stops slightly just short of the bone, and the gap between the muscle and the bone is spanned by collagen fibers. Most skeletal muscles are attached to a different bone at each end. One end, called the origin, the other end, called the insertion. The origin is the bony attachment at the stationary end of the muscle, shown here in the picture to the right, and the insertion, shown on the opposite end, in the picture to the right, is the bony attachment to the mobile end of the muscle. The belly is the thicker middle region of the muscle between the origin and the insertion. For the biceps brachii, the origin is on the scapula, and the insertion is on the radius. The terminology of origins and insertions, however, is imperfect and sometimes misleading. One end of a muscle might function as a stationary origin during one action, but as its moving insertion during a different action. For example, consider the quadriceps femoris muscle on the anterior side of your thigh. It's a powerful extensor of the knee, connected at its proximal end mainly to the femur and at its distal end to the tibia. This is just below the knee. If you kick a soccer ball, the tibia moves more than the femur, so the tibia would be considered the insertion of the quadriceps, and the femur would be considered its origin. But as you sit down in a chair, the tibia remains stationary and the femur moves, with the quadriceps acting as a brake so you don't sit down too abruptly or hard. By the foregoing definitions, the tibia would now be considered the origin of the quadriceps and the femur would be the insertion. And there's many other cases in which the moving and non-moving ends of a muscle are reversed when different actions are performed. Nevertheless, our book uses the traditional, admittedly imperfect descriptions of origins and insertions here. Some muscles insert not on one bone, but on the actual fascia or the tendon of another muscle or on collagen fibers of the dermis. The distal tendon of the biceps brachii inserts on the fascia of the forearm, and the facial muscles insert in the skin. Next, let's look at functional groups of muscles. The effect produced by a muscle, whether it's to produce or prevent a movement, is called its action. There's 4 categories depending on the action. A prime mover muscle, or an agonist, is the muscle that produces most of the force during a particular joint action. In flexing the elbow, for example, the prime mover is the brachialis. A synergist is a muscle that aids the prime mover. Two or more synergists acting on a joint can produce more power than just the single larger muscle by itself. The biceps brachii, for example, overlies the brachialis and works with it as a synergist to flex the elbow. The actions of a prime mover and its synergists are not necessarily identical and redundant. If a prime mover worked alone at a joint, it might cause rotation or another undesirable movement of a bone. A synergist may stabilize a joint and restrict those movements or modify the direction of the movement. So this makes the action of the prime mover a more coordinated and specific motion. An antagonist muscle is a muscle that opposes the prime mover. It relaxes to give the prime mover control over an action, but prevents excessive movement and injury. More often, the antagonist maintains some tension on a joint and then limits the speed or the range of the prime mover, and that prevents the excessive movement. If you extend your arm to reach out and pick up a cup of tea, for example, your triceps brachii serves as the prime mover of elbow extension, and your brachialis acts as an antagonist to slow the extension and stop it at the appropriate point. If you extend your arm rapidly to throw a dart, though, the brachialis must be quite relaxed. The brachialis and the triceps represent what's called an antagonistic pair. These are muscles that act in opposite sides of the joint. We need these because a muscle can only pull, not push. For example, a single muscle cannot flex and extend the elbow. A fixator is a muscle that prevents a bone from moving. To fix a bone means to hold it steady. That allows another muscle attached to it to pull on something else. For example, consider again the flexion of the elbow by the biceps brachii. The biceps originates on the scapula, crosses both the shoulder and elbow joints, and inserts on the radius. The scapula is loosely attached to the axial skeleton, so when the biceps contracts, it seems that it would pull the scapula laterally. However, there are fixator muscles, they're called the rhomboids, that attach the scapula to the vertebral column. They contract at the same time as the biceps, holding the scapula firmly in place and ensuring that the force generated by the biceps moves the radius rather than the scapula. And those functional groups of muscles are shown here that were just described, with the prime mover as the brachialis, the synergist as the biceps brachii, the antagonist, the triceps brachii, and the fixator as the rhomboids. In places like the tongue, the larynx, the back, the hand, and the foot, anatomists distinguish between intrinsic and extrinsic muscles. An intrinsic muscle is entirely contained within a particular region, having both its origin and insertion right there. For extrinsic muscles, they act upon a designated region, but they have their origin elsewhere. For example, some movements of the fingers are produced by extrinsic muscles of the forearm. Those long tendons of the forearm reach to the phalanges. Other finger movements are produced by the intrinsic muscles of the hand, located between the metacarpal bones. In order to get muscles to move, they must be innervated by a nerve. The innervation of a muscle refers to the identity of the nerve that stimulates it. This enables the diagnosis of nerve, spinal cord, and brainstem injuries from their effects on muscle function. Any innervations described in this chapter will be more meaningful after you have studied the peripheral nervous system in later chapters. The spinal nerves arise from the spinal cord and emerge through the intervertebral foramina and then innervate muscles below the neck. Spinal nerves are identified by letters and numbers that refer to the adjacent vertebra. For example, T6 for the 6th thoracic nerve and S2 for the 2nd sacral nerve. Immediately after emerging from an intervertebral foramen, each spinal nerve branches into a posterior and anterior ramus. You'll note references to nerve numbers and rami in many of the muscle tables. The term plexus in some of the tables refers to a web-like network of spinal nerves adjacent to the vertebral column. All of the spinal nerves named here are illustrated, and most are also discussed in later chapters. Cranial nerves arise from the base of the brain and emerge through the skull foramina. Then they innervate muscles of the head and the neck. Cranial nerves are identified by Roman numerals, such as CN1, cranial nerve 1, to CNX11, which is cranial nerve 12. It is interesting to note that not all 12 of the cranial nerves innervate skeletal muscles. In order to work, muscles must have nutrients and oxygen, and they must get rid of wastes and carbon dioxide. Therefore, they need their blood supply. The muscle system receives about 1.24 liters of blood per minute at rest, 1/4 of the blood that's actually pumped by the heart. During heavy exercise, the total cardiac output rises and the muscular system's share is more than 3/4 at about 11.6 liters per minute. Capillaries then branch extensively through the endomysium to reach every muscle fiber or muscle cell. Learning the names of muscles might seem like a forbidding task at first, especially when you see some of their long Latin names, like the ones listed here, the depressor labii inferioris or the flexor digiti minimi brevis. Such names, however, typically describe some distinctive aspect of the muscle structure or its location, its action, and it can become very helpful once we grow familiar with a few common Latin words. For example, the depressor labii inferioris is a muscle that lowers or depresses the bottom or inferior lip or labium. And the flexor digiti minimi brevis is a short, brevis means short, muscle that flexes the smallest, minimi, finger, or what you call a digit. Muscle names are interpreted in footnotes throughout your book. Familiarity with those terms and attention to the footnote will help you translate muscle names and remember the location, appearance, and actions of the muscles much better. You can listen to the pronunciations of these muscle names online by visiting a website called Anatomy and Physiology Revealed at www.aprevealed.com. In learning names of muscles, it's helpful to examine models, cadavers, dissected animals, or to look at a photographic atlas to get the visual images of the muscle. Also, when studying a particular muscle, try to palpate it on yourself if possible. Locate the origins and the insertions of the muscles on an articulated skeleton. Study the derivation of each muscle name, which usually describes the muscle's location, appearance, origin, insertion, or action, and say those names out loud to yourself or a study partner and spell them correctly. Flashcards might also help. Let's see if you can answer these questions. You can pause the video to see if you can answer them before I do. Number 1, list the functions of the muscular system. Remember, those were movement, stability, control of body openings and passages, heat production for our metabolism, and glycemic control. Number 2, describe the endomysium, paramysium, and epimysium. Well, remember, all of these are connective tissues that basically do some sort of bundling. So the endomysium, endo means inside, that is the connective tissue that bundles around a muscle fiber or a muscle cell. The paramysium bundles many muscle fibers together, and that little bundle then is called a fascicle. And then the epimysium bundles many fascicles together. Epi means upon or above. So the epimysium then would surround the entire muscle and then would eventually grade into the fascia. Number 3, distinguish between direct and indirect muscle attachments to bones. Answer: an indirect attachment is where the muscle seems to end just short of its bony destination, so then the gap is bridged by the fibrous band or sheet called a tendon. In a direct attachment to the bone, to the naked eye, it almost looks like the muscle goes all the way to the bone, and you might need a microscope to actually see that the gap is bridged by collagen fibers. Fourth one, define origin, insertion, belly, action, and innervation. Answer: the bony site of attachment at the relatively stationary end is called an origin, and then the attachment site at the more mobile end is the insertion. The middle, thicker region then is called the belly of the muscle. The effect produced by a muscle, whether that would be to prevent movement or create a movement, is called its action, and innervation refers to the identity of the nerve that stimulates it. Number 5, describe 5 basic muscle shapes. And I'm going to go back to this diagram to help us out. We have the fusiform, which is thick in the middle and tapered at the ends. Parallel, these have a uniform width and parallel fascicles. You can span longer distances. Triangular is fan shaped, tapering to one end to the insertion. Unipinnate, again the pinnate ones are feather shaped. In the unipinnate, the fascicles insert obliquely on a tendon and approach from one side. In bipinnate, it really does look like a feather. The fascicles approach the tendon from both sides. And in multipinnate, it's shaped like a bunch of feathers with their quills convergent on a single point, like the deltoid muscle. Circular muscles are a ring around a certain body opening. Sixth question, distinguish between synergist, antagonist, and fixator, and how do they affect the prime mover? Well, the prime mover, or the agonist, is the muscle that produces most of the force during a particular joint action. The synergist is a muscle that aids the prime mover. 2 or more synergists can make the motion more powerful than just the prime mover by itself. An antagonist is a muscle that opposes the prime mover. In some cases it might relax to give the prime mover more control over an action, or it might maintain some tension to limit the speed or the range of the prime mover so that there isn't excessive movement and it reduces joint injury. A fixator is a muscle that prevents a bone from moving or fixes it and holds it steady so that a muscle can pull on something else. All right, these next two slides, these are the same diagrams that you can find in your lab manual. So these are from Pearson. I like their diagrams, and I like how they have things labeled into categories here. These are the muscles that I would ask that you learn. I know many that are in this class are trying to get into programs such as nursing, athletic training, and such. It is important that you know at least some of the muscles. I know there's 600 muscles or more. It's hard to know all 600. So if you could learn these, I've picked out some important ones. You could know these, that would be a start and can help you as you enter your program to be more successful. So these are the front view muscles that I would like you to learn, and these are the posterior view muscles that you should learn. Some of them are repeats of the front diagram because you can see them from both sides. It would be nice if you could learn them so that if I were to give you these sheets with the labels not on them, you would be able to do so yourself. That looking at this, you would know that this is the deltoid muscle here without having the label on there. So please take some time and try to learn those muscles. You may find some questions about them on your lab practical number 3, as well as our chapter 10 and 11 test, and on the final. Then I'll give you a note here. We've completed the notes on the first section of the textbook in chapter 10. I have included the rest of the slides, but we are not going to go over them in class. They get very detailed about descriptions of specific muscles and different areas of the body. I suggest reading through that. Don't just ignore it, but read through and look at the pictures of those muscles, look through some of the charts, and try to go back to these two diagrams here and pick out the ones that I've asked you to learn and really focus on those. Look at their origins and their insertions and other related muscles, and what are their locations, and what do those muscles actually look like. In some of the pictures, they may also have a cadaver, or they might tell you what those types of muscles are capable of doing, what are their actions. Then lastly, I wanted to jump down to this slide on carpal tunnel syndrome, since it's such a common problem in today's society. The flexor retinaculum is the bracelet-like fibrous sheet which the flexor tendons of the extrinsic muscles that flex the wrist pass on their way to their insertion. And the carpal tunnel is the tight space between the flexor retinaculum and the carpal bones. The flexor tendons passing through the tunnel are enclosed in tendon sheets, and that enables those tendons to slide back and forth quite easily. With prolonged repetitive motions of the wrist and the fingers, it can cause the tissues in the carpal tunnel to become inflamed, swollen, or even fibrotic. Since the carpal tunnel cannot expand, swelling puts pressure on the median nerve of the wrist, which passes through the carpal tunnel with the flexor tendons. This pressure causes tingling and muscular weakness in the palm and the medial side of the hand, and then also causes pain that can radiate up to the arm and to the shoulder. Again, that condition is called carpal tunnel syndrome. It's common among keyboard operators, pianists, meat cutters, and those who spend long hours making repetitive wrist motions. Carpal tunnel syndrome is treated with aspirin and other anti-inflammatory drugs. immobilization of the wrist, and sometimes even surgical removal of part or all of the flexor retinaculum to relieve pressure on the nerve. Another last note I'd like to draw your attention to is the last slide on common athletic injuries, which also has a section covered on that in the textbook. Unfortunately, muscles and tendons can be very vulnerable to sudden and intense stresses that athletics can place upon them. Therefore, proper conditioning and warm-up is needed. Each year, thousands of athletes from high school to professional levels sustain some kind of injury to their muscles or to their tendons and ligaments. Overzealous exertion without proper conditioning and warm-up is frequently the cause. Compartment syndrome is one common sports injury that we've discussed already. Baseball finger is another. This is tears in the extensor tendons of the fingers resulting from the impact of a baseball with the extended fingertip. Blocker's arm is the abnormal calcification in the lateral margin of the forearm as a result of repeated impact with opposing players. Charley horse. Many of us have had these. It's any painful tear, stiffness, or blood clotting in a muscle. A Charley horse of the quadriceps femoris is often caused by football tackles. A pitcher's arm is inflammation at the origin of the flexor carpi muscles, resulting from hard wrist flexion in releasing a baseball. Pulled groin is a strain in the adductor muscles of the thigh, common in gymnasts and dancers who perform splits and high kicks. Pulled hamstrings is a strained hamstring muscle or muscles, or a partial tear in any of their tendinous origins, often with a hematoma or a blood clot in the fascia lata. This condition is frequently caused by repetitive kicking, like in football and soccer, or in long, hard running. Rider's bones is an abnormal calcification in the tendons of the adductor muscles of the medial thigh. It results from prolonged abduction of the thighs when riding horses. Rotator cuff injury is a tear in the tendon of any of the rotator cuff muscles, most often the tendon of the supraspinatus. Shin splints is a general term embracing several kinds of injury with pain in the crural region, tendinitis of the tibialis posterior muscle, inflammation of the tibial periosteum, and the anterior compartment syndrome. Shin splints can result from unaccustomed jogging, walking, or snowshoes, or any vigorous activity of the legs after a period of relative inactivity. Tennis elbow is the inflammation of the origin of the extensor carpi muscles on the lateral epicondyle of the humerus. It occurs when these muscles are repeatedly tensed during backhand strokes and then strained by a sudden impact with the tennis ball. Any activity that requires rotary movements of the forearm and a firm grip of the hand, for example, like using a screwdriver, can cause the symptoms of tennis elbow. Tennis leg is a partial tear in the lateral origin of the gastrocnemius muscle. It results from repeated strains put on the muscle while supporting the body weight on the toes. Many of these athletic injuries can be prevented by proper conditioning. A person who suddenly takes up vigorous activity or exercise might not have sufficient muscle and bone mass to withstand those stresses. They must be developed gradually. Stretching keeps ligaments and joint capsules supple and can help reduce injuries, and warm-up promotes more efficient and less injurious musculoskeletal function. Most of all, moderation is important, as most injuries simply result from overuse of muscles. No pain, no gain is a dangerous misconception. Muscle injuries can be treated initially with rest, ice, compression, and elevation. Serious injuries like compartment syndrome require emergency attention by a physician.